let's talk about some of the CDC-funded Neisseria gonorrhea drug resistant surveillance that's being done. And some of you may be familiar with gonococcal isolation surveillance project, often called GISP, which is in existence for many years for most of the male erythral gonococcal surveillance for STD clinics. But for the purpose of talk today, I'll be focusing on another CDC-funded gonorrhea surveillance project called Strengthening U.S. Response to Drug Resistant Gonorrhea, often called SURRG. And City of Milwaukee is one of the 8 sites nationally. Since 2016, we are involved in that, as you see in the map here. And then primary focus here, enhancing the domestic gonorrhea surveillance and the building the infrastructure, because it's not there yet enough of those. And then also the building and expanding the capacity, because local AST or antimicrobial resistance surveillance is critical, and then how that may be impacting the field investigation case follow-up. So let's look into some of the options of the testing and the collection. At your left, as you see that, eSwab and InTray are the 2 primary collection and the transport media that currently being used. At the bottom, there is a publication that we did a study with CDC prior to SURRG involvement, that how critical it is to look into the right transportation media, because Neisseria gonorrhea is hit labile, and we have to make sure that we handle it with care. And once those are isolated, it could be on the chocolate slant agar, and then in the lab, we use the biochemicals, and then MALDI-TOF and the NAAT testing for identification. And then at your right, these are the phenotypic susceptibility testing that currently being used. And the top one is the distribution. Many of you are familiar with maybe the Corby-Bauer, often call it like with that name. And the bottom one, the e-test, is what currently being used in most of the SURRG sites. So this is looking into the minimum inhibitory concentration MIC, and it is a strip of different gradient of antibiotics. And this could be used for the quantitative interpretation. It's a very cost-effective and quicker turnaround time. In the middle, the agar dilution is still considered as the gold standard, but it could be costly and time-consuming and need the expertise in the lab. And at the bottom, there are 5 different antibiotics that's currently being looked at for the surveillance, including ciprofloxacin, cefixime, ceftriaxone, azithromycin, and we also added gentamicin, which is one of the injectable drugs. So why we are doing it? Of course, like any other major city, that we have a high-risk population, and we have a varieties of STI testing and the NAAT in place. But primarily for the GC AST, we look into the outbreak investigation, treatment failure. I'll talk about the DGI, which is disseminated gonococcal infection situation. And all those are being currently used for the testing, either NAAT or culture, and then antibiotic resistance testing. We're really fortunate to have multiple different partners involved in that, primarily our STI HIV clinic, student health. We have the local universities, outreach clinics, Planned Parenthood of Wisconsin. We are just embarking with the jail and the correctional facilities, and great partnership with Wisconsin DHS and CDC STI prevention branch. So let's look into some of the data, and what you are seeing on the top plot, we call it as an alert for those that we have seen some resistance or reduced susceptibility. We call it based on the SURRG definition. So here, most of those data here between 2017 and all the way end of last year, we have seen significant increase in the azithromycin resistance, which are in the blue bar. We have seen only very few cases of cefixime and ceftriaxones, but we have seen some quick alert, we call it, if we have seen close to the resistance being full resistance. But at your right, as you see that giving the azithromycin trend is in all over the country, we kind of moved into looking into ciprofloxacin, which found out to be some resistance, but based on our clinical guidance from the local jurisdiction, we wanted to see salvaging using the cipro for those who are susceptible to that. So this is interesting information, and really we are expanding on this to be the center of excellence to expand our SURRG effort throughout the state. At the bottom, information only, the table has all the different antibiotics, their alert values, and then CLSI recommendations. So this slide talks about the antibiogram for Neisseria gonorrhea, which is really a critical piece of information both for the clinicians and the infection control, as well as the antibiotic, managing the antibiotic in the healthcare setting. So as you see that we captured the 3 years of data and related MIC that we have seen, mostly based on the agar dilution data. The penicillin and the tetracycline data presented here is currently not being used by the SURRG sites, all the 8 sites, but is being used by CDC and our advanced regional labs, ARLMs. So what next? I think the enhancing antibiotic-resistant gonorrhea is a critical areas of expansion that we need to see not only in the United States as well as globally. As I mentioned, that we are all looking into being the center of excellence to expand our preparedness and response to our ARGC. But to do that, we really need to have the protocols in place and the outbreak response plan in place. It's working in collaboration with our AP partners. We are piloting implementing the molecular assays like culture independent diagnostic for the GC surveillance, and then potentially looking into the next-gen sequencing and other advancement. So overall, I think this is also to promote the GC resistance and surveillance across the jurisdictions. So some of the critical piece here is that, building infrastructure to expand the targeted genomics approach. And I'll be happy to talk about in the Q&A session. But I think the critical thing is that optimizing the genome sequences. For those who are already using those for COVID and any other program in the public health, I think we still need to work on the bioinformatics algorithm and detection of the co-infection. And what are those outcome measures that we can do and get the benefit of the culture-independent testing? Whether those are direct targeted amplification, real-time PCR assay for the AMR marker, or could be used in the field or targeted genome sequencing. So we are already working towards with the CDC and the SURRG partners to have a point mutation-based and a targeted amplification. And then we are hoping to implement that in near future as well. So this is my last slide. So this shows one of the publication from the STI journal that we had looked into some genomic approach looking into the surveillance. Typically, as you know, traditionally we do the phenotypic surveillance, but genomic will allow us to get into the quicker turnaround time and better identification or case investigation in more near real-time basis. Treatment failure and disseminated gonococcal infection, which when Neisseria gonorrhea drug resistance could be in the bloodstream, is at the high-risk situation and many potential clinical manifestation. I think this is the future, and we are all working towards. I'll stop here, and thank you for your patience and listening to this.